Going live duel again with folks on YouTube and on here. I'm gonna have to start announcing on YouTube because they never know when I'm going live. Actually, y'all never know either, but we're gonna try and do better about that. Hey, so we got some folks that are starting to come in. The Candace Parker. Hey, how are you doing, Candace? And let's see, Amy. Hey, Germ Worm. I love it. That's awesome. Welcome. Um, This is the first time I've actually done a live when I'm actually at work. Usually it's a Saturday morning thing, when I can finally get around to it. But I had a few minutes actually here at lunchtime, so I'm giving it to y'all. Good morning, Amy. Thank you for the hello. Uh, Lisa, Cindy. So, a couple of rules in my lives. I cannot give you any direct medical advice about something specific to you. I can tell you what I would do in your shoes. Hey, Lupe. Good morning. I can tell you what I would do if I was in your shoes, but I cannot. You cannot interpret that because we don't have a doctor-patient relationship. But that being said, uh, uh, I Candace, I really hope that gets better for you. I'm sorry. Uh, I agree that there's a lot of need there, so I'm praying for that. Hey, Lise, good morning. So love to have all this people here. Love the interaction. So this morning, or this afternoon, I guess it is technically still more. No, it's actually anyway. For me, it's afternoon. I'm about 12:30 here. Um, and what I was going to say was that I wanted to talk a little bit about IBS today, and in addition to whatever topics y'all bring up. Someone asked me in a live the other day about some of the best drugs for IBS. And so, first thing I wanted to start with was I'm going to talk about some over the counter stuff. I know none of us like Miralax as far as you think about that white powder and you think about how thickening that stuff, but it is very useful. And I wanted to say to you that, yep, that's where it needs to be. I don't know why you brought up the INR levels, but that is the range that you wanted in. Anyway, um, the Miralax is very useful. It's best tolerated in juices like orange juice and coffee, but you want to have it in at least 8 ounces. I like 16 ounces of whatever I'm drinking it in. And you really need to. It needs to be when you're using Miralax. It needs to be. Oh, thanks, Anne, for the backup. It really needs to be an everyday kind of thing. It will not tend to give you diarrhea. It just will tend to reach a maximum level of effectiveness and then not work further than that. Um, so when that person was asking about IBS drugs, I just want to make sure that we don't jump you right to pharmaceuticals. Miralax is basically a supplement. It is a medicine, of course, but it is a medicine that's not systemically absorbed, and it's basically a supplement. That's why it's available over the counter now. Cold tea, as long as it doesn't detract, as long as it doesn't feel like I'm chewing, is my biggest thing. How related is chronic pain and GI? Like hand in hand? Absolutely. Especially if you carry it in your gut. Especially, I think GI is related to almost everything. I think GI causes and GI responds to almost every other problem. So when you're having chronic pain, you're going to have chronic GI issues. If you're going to have chronic GI issues, believe it or not, you can also have chronic pain. So, oh, okay. Amen. So, Candace, I'm going to assume that you've got some liver disease there. And Xifaxan is fantastic for hepatic encephalopathy and staying out of it. Carafate's really good more for ulcers and things like that. Crohn's and colitis, lots here. I have both. Any suggestions? Okay, so let's go beyond. Then let's get beyond Miralax. What do we do when Miralax doesn't work? Can we just agree that if you haven't tried Miralax, that's our baseline? So what do you do when it doesn't work? Um, Number one thing that I like to start with in the pharmaceutical area is I like to start with, believe it or not, a drug called Amitiza. So Amitiza, there are three drugs in the class that Amitiza is in. Again, Miralax, coffee, good job. But there are three drugs that are in the class that Amitiza in. Amitiza was the first drug that came out. It's available in two different doses, 8 micrograms for IBS and 24 micrograms for a lot of other things. But it's even been used for opioid-induced constipation, although I don't think it works very well in that area. But the reason why I like it is it's the most gentle of the three drugs in that class. Okay, Linzess, and you may have heard that Linzess for IBS-C is very effective, but it's probably the strongest drug in the class. And so, almost like the three bears, my favorite drug in the class tends to be the one that I feel like is just right, and that is Trulance. It's spelled Trulance, and you can Google it later to talk to your doctor about it. But it is the one of the reasons why I like it is it tends to get in, do what it's going to do. And, they all work indirectly or directly by adding water to your stool to the point that the large intestine cannot fully absorb it, and that of course causes your stool to be looser and allow it to pass. Okay, but Trulance does this in the most time predictable fashion. So the reason why I like it, because I have IBS-C and I don't have to take something every day, but I have tried all three of the medicines, so I know firsthand. But that's the one that you can take, and I feel like in about 4 to 6 hours you're done. Yes, water, water. Agreed. Thank you for saying that, Candace. But it even more than the water, water. Don't forget fiber. But at the end of the day, sometimes it's not the things you're doing. Sometimes it's not your diet. I think a lot of times when people have issues with their gut, some of us just run slower. Okay, our normal plumbing doesn't quite isn't quite up to the task. Okay, and a lot of times, and I'm going to take a rabbit hole, and I'm not going to take a rabbit hole. There's a rabbit hole I can go down in that, but I'm just saying sometimes it's not enough. Sometimes you just got to do a little bit of medicine with it, but don't overlook thank you, Nancy. What I appreciate when someone says that don't forget your water and things like that. A pill is not a plan. Y'all have heard me say it on my videos a lot. When it comes to this, a pill is not a plan. It's dietary. It is what you're eating. It is how much you're eating. It's when you're eating it. It's water consumption. It's drinking water, not sodas. It's all of that, and not one of those things is probably going to be the magic bullet. It's a comprehensive plan. So definitely talk to your doctor about this. Let's go with a different topic. Why don't y'all pick now? I got to talk about poop for a while. Why don't y'all pick one? What else you got on your minds today? Thank you, Lisa. I appreciate all of you that appreciate me, because honestly, live is why I do this. It's the funnest part. I can't always fix everything I see in comments, and honestly, that hurts sometimes, because I really want to be. I wish I could just touch some of y'all and just make the problems better, but I just don't. Jesus didn't give me that power. That wasn't. Ooh, cryotherapy for shoulder pain. Andrew, hey, it's good to see you, brother. I'm not sure. The um, I'm not sure that I have an opinion, Andrew, on cryo for shoulder pain, because I haven't used that modality. This is going to be one of those ones where I'm going to say this. Don't expect it to do more than. I think that sometimes cryo therapists oversell it, but other than that, it is not harmful, and I recommend that. Thank you for that, all of you that are just and yeah, I saw that. I beg your honest opinion. I like that, but yeah, I appreciate that. And the doctor wants us to increase his med count because of his, huh? The doctor won't. Is that what you're saying? Perfect, Paul. Is that you saying that he won't because of his diabetes? I can come back to that. Thank you for that. I appreciate that. I try to. All right. Um, Perfect. Let's talk about that for just a minute. We're going to stick on what she's at. It says, why would a doctor? Why would a doctor not? Uh, yes, Amy, I do, but let's save that for another day. I will try and do another lunch, and you can also ask me anything under questions and answers, Amy, for any female issues. I'm a no holds bar guy. Take it with. If I don't know, I'll even tell you that. But let's go back to why won't a provider increase? I'll tell you the number one reason why he's not increasing the med count for the diabetes is he's probably assuming that some of the pain is due to his neuropathy being made worse by his A1C count. The thing about it is I definitely understand the frustration about about what seems like a roadblock. And why would somebody not, diabetes and pain? They're not really that they don't seem to be. One doesn't seem to lead to the other. But, um, and all of you, by the way, if you're not getting your question answered, I do watch for my question and answers, and I do try and do videos related to that. So don't hesitate to leave me questions. And if I don't answer it on this one, I'll answer it on my other account that where I focus less on chronic pain. But anyway, so the point being, Paul, the point being there, perfect, is that if we can get his A1C under better control, then we can more clearly see what his current level of pain control is. But if your diabetes is out of control, your pain's going to be out of control. And chasing it with more pills may not be in his best interest. So I don't know. I'm not saying that I agree or disagree with the provider. I'm telling you why I might have a pause. And so I do think, whether you agree with him or not, that getting the A1C down is going to help. I do think you need to get it down because it really does obscure the effectiveness of the pain treatment plan, and you really can't judge it until you get that A1C. At least get it below 8. It may even maybe not below 7. It might be a little bit unreasonable to get it all the way down. But if you're anywhere near 9, 10, or 11, it's hard to try and get your pain managed. And that is the truth. Okay, Jamie, let's talk about your the ruptured disc, and is it a bad surgery? None of it's bad surgery. What I want you to do is this. I want you to have a very specific conversation about what you expect the outcome of the surgery to be. And they can't overpromise, but I do want you to have an understanding. Is this going to increase my function? Is it going to decrease my pain? Is it going to do both? Is it going to do one or the other? The most important part of the reason why a lot of people feel like they had bad surgeries is they did not go in as informed consumers. So don't rush into it. Take the time, ask lots of questions. And then here are my two pieces of advice for anybody that has back surgery. One, don't do a damn thing that they tell you not to do. In those first 2 weeks, if they tell you not to lift anything above 5 pounds, don't lift anything above 3. Okay? If they're giving you those limits for a reason, they are messing with what God fearfully and wonderfully created from the inside out, except they're going from the outside in. And when they first fix it, everything is fragile. So don't do a thing they tell you not to do. Number two, when they give you the go ahead, do everything they tell you to do. If they tell you that you're supposed to do 10 jumping jacks, and they won't, but if they tell you, okay, here's a good one. If they tell you to bob for apples 10 times a day, bob for apples 10 times a day. Okay? Do everything exactly like they say, because that's what's going to give you the best outcome. I will, okay, perfect is not wrong. It is good to have a pain management doc because, again, one of the things that the perfect saying is that it's really hard to start chronic pain management after back surgery, and it's better to almost to a certain degree to be on low grade pain management before you even have surgery, and then realize that the surgery is going to fix some things and not other things. But it's hard. It's hard. What can you take from, okay, PNW? ask me that in the question form because I'm gonna. If that's a big topic, and I really the most important thing is that usually I'll say it this way. PNW. Here's your answer. You don't have to do that. Here's your answer. Most things that don't involve um, I'll come back to that, Jamie. But most things that don't involve Tylenol are okay for you to take. Um, and ask your doctor though. Okay. And remember, I can't give you direct medical advice, but mostly it's Tylenol that's off the table. Um, well, I tell you what, Amy, if you've been watching on TikTok, there's a lot more of us out there. I think I'm becoming a little bit less of a unicorn. There are some really good content creators that are coming out now. All right. It's I don't know. Let me go back to there was something. Sorry for Nancy. Chronic renal pain syndrome can be very difficult. I'm sorry for that. Remember, I'm not gonna get okay. Okay, so let me ask you a question. Let's stay on that for a second. It's about the bilateral amputee and the umbilical hernia. I'm going to stay on that point for a mission. I have a clarifying question. The clarifying question is, why does it need to be fixed? He said recovery could be tricky. I think he probably means Healy. Why does How big is it? Is it got to the point where there's absolutely no alternative but to fix it? Because I would say that to a certain degree, if the umbilical hernia, I would leave it until it had to be fixed. I love that description, petri dish. I feel like I'm a petri dish some days too. I don't have the autoimmune stuff, but man, getting old is not for sissies, is it? Um, anyway, go Tigers fan. Okay, that's how that says it. Some of y'all's names are so creative. It's hard. I have to figure it out. Celiac disease genetic. While I'm waiting for Go Tigers, yes, celiac disease can be. It has a genetic predisposition. It is not a inherited disease, but genetic predisposition. It runs stronger in families. And I will say this: whether you have celiac disease, if you do the test for celiac disease or not, excuse me, if you are determined to not have celiac disease, changing gluten in your diet can still be helpful, even if you don't have celiac disease. Amen. Getting better is better than the alternative. I haven't seen anybody sign up for the alternative plan. Tractable migraines. Okay. Um, I will tell you this. My next live is going to be about migraines. So I will say this. If No, PNW. I know that it doesn't seem like life is worth living some days, but I got to tell you that I want you to hear. I mean, even today, you just being in live, it's just an encouragement. You don't understand and realize just how much value you have to other people. So just want to make sure I speak against that. But the next one is going to be about migraines and specifically old treatments that do work, new the CGRPs and everything related to that. Okay, all right. So basically, you're feeling like okay. So that umbilical hernia, go Tigers, is the worry would be can it become incarcerated? And based on the fact that you do any physical activity and you have to, just getting out in and out of the chair is physical activity for you. Um, Besides the fact that you have two amputations, why did he say that it's tricky? Do you have diabetes too? Okay, but go Tigers. You have diabetes as well. Um, as far as none your business, I almost want to say none your business, but in all seriousness, I hope that it's going to be another lunchtime this week. Okay, so I will try and post a video the morning of to let you know when I'm going to go live. Okay. But borderline diabetes? Okay. How well controlled is your blood pressure? See, these are the things that what's made I have a suspicion that what he's saying is that healing may be tricky, but the most important thing he's telling you, let me just say this. If I'm telling you that healing can be tricky, what I'm saying is let's have surgery a month from now. Let's get some stuff straightened out. Your question to your PCP is this: how can I make my healing less tricky? Do I need to quit smoking for 2 weeks before and 2 weeks after? Something along. How do I ask your PCP directly? My surgeon says it will be tricky. Your PCP has all the information to not make it tricky. Okay. Anyway, I do hope the migraine conversation will be at lunch sometime this week. So I'm looking forward to that because it won't be a one-time thing. Migraines are tough. I have a paper. I think you mean a PCP. Um, for those of you that are dealing with that, I'm empathetic. Oh, okay. All right. I'm about to do something. I'm going to tell you something. Go Tiger. That's going to be a little bit gaslighting. And I say that just because you say the word mesh, and everybody goes, "No." I've had mesh since 1991 in my right groin. I'm not saying that everything is fine with all things mesh, but if you're a W amputee, your surgery is probably going to require mesh in order to hold together while you do all the things that you have to do. So just don't be gaslit when he mentions having to do that. Okay, it absolutely can go well. Other thing, I'm going to tell y'all, and this is probably going to be where I have to end today. I'm going to give you one more bit about any abdominal wall surgery. Expect chronic pain afterwards. Not that you're going to need pain medicine forever. Expect it to always hurt. And let me illustrate for you why, because when I illustrate, it's going to make perfect sense. They take that mesh and they tack it to 6 or 8 points on each side. Now, whenever you move, you pull those. You create abdominal force pulling away at all the points that are tacked. Okay, and just like having your tooth stuck to a piece of string and on the door, and okay, it's always pulling. Okay, so just know that pulling motion itself causes pain, and that pain is absolutely normal, and that it's gonna be okay. I think anybody that has abdominal wall surgery just needs to know my belly's gonna hurt, and it's okay. Scar tissue hurts too, Nunya. I'm not saying it doesn't, but as it relates to I don't think that they really. I think that they don't tell them what the physics are when you tack a mesh onto otherwise. So you have an immobile mesh on a mobile abdominal wall. It causes pain. Y'all, this has been a great live. I've enjoyed your comments and your time, your support. I love y'all. I think you've seen enough of my videos to know that's like Jesus right there, y'all. He loves you. I love you. No buts. Have a great day. Y'all have a great day too.